Well, good afternoon. It's wonderful to be here. I'm Susan Bonilla, the CEO for CPHA. We're so excited to be in Las Vegas this year for our Western Pharmacy Exchange and really excited to be partnering with all of you. You know, we're thoroughly convinced as we look at the future of pharmacy that those of you who are gathered for the Right Meds Collaborative Conference are on the right track. You are definitely ahead of the game. You are pointed in the right direction and really going to be instrumental to taking pharmacy to where we need to go. And so thank you so much for coming together, for partnering with us at WPE. We really appreciate that. You get Steve all afternoon. We're lucky to get Steve Chen speaking tomorrow morning as our keynote speaker at WPE, and we're really excited about that and are looking forward to that very much. And it's my honor to introduce the president of CPHA, Dr. Richard Dang.
Hi, everybody. Good to see you all. Thank you all for joining us. Great to see familiar faces, both in person and virtually on Zoom. Just want to welcome you to our WPE conference, and we're so glad to be able to host CRMC here with our conference. The work that you guys are doing, as you know, is so important, so influential, and really is the future of our profession. And, you know, in my role as faculty at USC, I'm one of our community pharmacy faculty members. And so I very much believe in this mission of this collaborative and truly believe that the future of our profession, the advances that we're going to be making will be in the community pharmacy setting. And you guys are helping trail that blaze forward for everyone else in the state and nationwide as well. So thank you for all your work, and I hope you have a really great session. I'll be all around throughout the conference, so please feel free to come up to me, say hi, and interact with me. And I would love to hear some of the work that you guys are doing if I haven't had a chance to already meet you or speak with you. So thank you all and have a great meeting.
Still not. Okay. Thank you both for stopping by. I really appreciate it. When we had this conversation about whether we could partner with CPHA, I was thrilled with not just the willingness, but also the excitement about supporting this work. So I know there's not a lot of people on site. Most are online, like I said, and we're looking forward to growing this and promoting it in a way where we can make this a lot bigger next year. So thank you both for stopping by. Really appreciate the support. Thank you. Okay. So we had a couple of technical issues, but I think we're good now. Right. Okay, so someone can't hear online. Oh, and others can. So, so whoever online can't hear, I think you might want to check your settings. It sounds like most people are able to hear online. Can't ask anybody here because you're all here in person. All right, I'm just trying to figure out. So this is our first run, so I apologize that for some reason I am not able to advance slides. Boy, everything's going a little wrong today. Let me see. You're right. I do, and it's also not working. Give us one moment, please. Okay, thank you. All right, thanks so much. Thanks for the help. So just to frame why we're here today, we talked about this before, but we're here to advance what truly is a proven framework for optimizing medication management, comprehensive medication management, and we're doing it in a way that makes sense, right? We're not trying to push fee for service, we're trying to push value. And we're only able to do that because of our health plan partners. So we're really grateful that they're here today and able to share what they're doing in this space. Before we get too much into this, wanted to run a quick poll. I think Lisa's gonna run this for us. Can you guys complete the poll if you can see it online? Okay, asking your professional role. whether you're a current CRMC care provider. I know there are some that are not. And in the chat, we want you to type, what do you believe are the 1 or 2 most important untapped opportunities for pharmacists? Okay. Give you a minute to do that. Okay, I see the 1 and 2 being answered. Not many opportunities that you guys are identifying yet. Okay, payment for service, maybe on the wish list. Not sure if it's an opportunity. Okay, anything else? Certainly is an opportunity if we can line up with value, right? For sure. Okay, working with physicians, payers, and patients to attain health goals, absolutely. Galvanize, I love that one. Galvanize community members to the value of CMM. All stakeholders need to understand it better, for certain. Okay. Integration with med groups, clinics, yes, absolutely. Okay. All right, collaborative practice agreements, yes. Okay, we're going to let those accumulate during the conference. Please continue to put those items in there. We collect this information, and they're things that we put into our next session as well. So, can I end the poll? Yes. All right. So we have mostly community pharmacists, I see. Some health plan. We have actually those that answer, the majority are not CRMC care providers. So welcome. Thank you for joining. All right, that helps a lot. Thank you. Okay. I'm not advancing again. Did it disconnect? Okay. Sorry, not able to advance the next slide. Give me a second here. Okay, thank you. All right, I'm going to accelerate our intro because I think we burned out a little time due to tech difficulties. This is the day as it's going to look. You can see that we already did the keynote, so we're not going to do that this year. We're going to jump right into some work and finish this up within 4 hours. Big theme is mental health, something that all of the current teams have cited as challenges among these high-risk patients that they're serving. So we have that covered today. We're going to have some breakouts that are specific to both mental health and some general issues, some challenges with engaging and retaining patients, as well as hypertension management being a core of everything that we do in this program. And then we'll be able to wrap up. Oh, okay, I didn't advance that, but good. So I just wanted to cover, for those of you that did not participate in the keynote that happened last month, we had some powerhouse speakers come and share some very insightful information about the state's healthcare plan and some thoughts on how we can be better engaged in advocating for the profession. Jessica Nunes de Ibarra from CDPH, she's a medical leader for the Chronic Disease Control Branch, and Liz Helms, President and CEO of the California Chronic Care Coalition. And I can't advance. Can I just ask to advance the next slide? Would that be okay? Next slide, please. Thank you. So in recap, very quickly, Dr. Jessica Nunes de Ibarra spoke about the major health disparities that we've known about for a long time, but have gotten worse since the pandemic. Death rates have actually risen in 2020 and 2021, not entirely attributed to COVID, especially among younger adults. The death rates have increased apart from COVID, which is a bit frightening. And we were already doing poorly before COVID. It's higher in underserved communities, really not it's disappointing, but not surprising. And broadly, she spoke about a lack of trust in healthcare, right? We've gone through 2 years of a pandemic, so many struggles with what to do and not believing some of the authorities. But where there is trust that was gained is among pharmacists, right? Pharmacists never closed, they were on the front lines giving immunizations. They were trusted in this pandemic. And the polls show that during this pandemic, trust in pharmacists have risen. And this is something we need to leverage. And then she talked about the critical need for comprehensive medication management. Next, oh, okay, I was able to move that one. And she talked about public health and this breakdown into 3 buckets of prevention. There's the traditional clinical prevention, which happens in traditional clinical settings. Number two, what they call innovative clinical prevention, which takes place in non-healthcare settings, such as pharmacies, such as other places, barbershops, et cetera. And three, just general population health initiatives that widely benefit the population. And what she pointed out as a physician, as a state healthcare leader, is pharmacists impact all these domains. We're in the communities, we're in clinics, we're in hospitals. So we have the ability to impact outcomes in every one of these areas. And if you look at the CDC's 618 initiatives, and you look at the 6 high burden conditions that they're tackling, every one of these pharmacists have a big part in or can have a bigger part in. So her point is, this is a time to step up. And further evidence of that is this move that California is heading towards with their Public Health 3.0. This is probably a lot of more information than would be helpful, just general labels, leadership workforce changes, strategic partnerships, getting timely data, analytics, and that sort of thing. But more importantly, is there's money coming in, a lot of money coming to the States. We're talking many, many billions of dollars in behavioral health, in CalAIM, which is DHCS's strategy for reforming Medicaid, and the goal of reducing Medi-Cal premiums to zero. So we're talking about a lot of money coming in, a lot of money being spent. Under that CalAIM, by the way, there's something called enhanced care management. There's targeting high-risk patient populations, such as transitions of care patients, mental health, jail transition populations. By 2023, there'll be a massive expansion of the patients that are targeted by this program. And there's going to be a need for services. And what Dr. Nunes de Ibarra openly stated is they are building this plane as it flies. There are not a lot of answers on how to address these things. So her message to us as a profession is we need to step up and take advantage of these opportunities. Liz Helms continued on talking about all the amazing partnerships she has and how she's able to get these groups together. They're seemingly disparate, but come together for the benefit of patients and for the betterment of the healthcare system. And I don't know if you all know, but she was instrumental in passing SB 493 in California and getting the 2 state associations to work together and in diffusing any resistance from the medical side. So she's got tremendous insight as to how to make policy work. End of the day, this all translates to us into we need better results from medications, right? Medications harm, kill, waste billions, hundreds of billions of dollars, and these are preventable with medication therapy optimization through comprehensive medication management. And one way to look at this is in a given population of care, there are a broad variety of interventions that are necessary to optimize health. And what this pyramid is trying to depict is as you move up the pyramid, you're talking about a quicker and larger return on investment when you invest in those populations. So at the very top, you have the high-risk patients, expensive patients, emerging risk patient populations. These patients are best served by programs like comprehensive medication management, which are outcomes focused, which are value-based that drive patients to goal. TOC, disease state management, fit in that category. Then you have a big bunch of regulatory quality measures and targets, MTM, TMRs, med adherence. These programs are available for those. And then down the bottom, not that it's not important, it's probably the most important, are the preventative health program services, many of which happen in community pharmacies. Again, just an example of all the areas where pharmacists can have a huge impact. And we really need this, right? Because as we come off the pandemic, this graphic, which came out in early 2020, predicted a 3rd and 4th wave and predicted it very well. Honestly, not many predictions came out correct when it came to the pandemic. This one did. And unfortunately, the 3rd wave is here. The patients that had neglected healthcare over the last couple of years are coming back with a vengeance, are overloading the healthcare system. The 4th wave, psychological trauma, mental illness, economic injury, burnout, and you can add health inequities, health disparities there is also upon us. So we need to accelerate this work to improve outcomes for patients. And we're doing this here through the California Right Meds Collaborative. Again, thanks to the partnership we have with health plans that makes it work. The vision is to optimize medication therapy for patients within their communities without having to utilize the healthcare system, the traditional healthcare system. And the mission is to create this network of pharmacists that can provide sustainable high impact CMM in alignment with health plan and pop health priorities. So I just use this just to make it simple for those of you that are new to the collaborative. Health plans have high to low risk patients that they stratify and identify that could benefit from comprehensive medication management. They facilitate the enrollment of these patients into CMM programs with these networks of pharmacies that we work together with them to curate, to train, to get ready for these services. And we work with different pharmacy schools as well to help cover and support these different programs. So our assertion is, for today, is comprehensive medication management saves money, lives, and is essential for high-risk patients to reach treatment goals and achieve health equity. This is an indisputable assertion. Whether you have insurance or not, I've worked in all settings, you can have a really horrific medication regimen that on board. And CMM is very important just for high-risk patients. The question we want you to run on and think about as we go through this is, what key insights will you bring back to your organization to optimize medication therapy for your most vulnerable high-risk patients? And how we want you to be today, again, pretty short session today, no more than 4 hours. Focus on the purpose I just shared with you. Teaming and interacting with each other. You're going to be doing it online or in person. We're going to have you actively listening and learning. Learning what best practices are, what proven methods are. Challenging yourself to think differently, right? These are very challenging patients to work with. Those of you that have not worked with this highest tier, 10, 15% of patients in any health system, think about how you can support them differently. What do you need to be successful with them? And then leaving in action, probably most importantly, make your requests today, make your offers today, make your verbal commitments to action. Because right after this learning session, we have action periods, we have webinars, we have support to help you elevate your ability to deliver comprehensive medication management. Quick housekeeping, Lisa McDonald has been billing me out already. She's our Associate Director of Continuing Professional Development. She helps with their CE issues. Online, we have Annalise Wilkins and Shaden Das, our QI specialists and our project manager, who are available. You can find them in the chat if you have any questions. We will share CE instructions throughout the program. If you want to scan this barcode, please complete the survey for the LA County Department of Public Health. They always survey us during these meetings. They are tracking what pharmacists are doing in the field of med management. Okay, and again, with that, I am going to hand off to Dr. Jessica Abraham. She is our Director of Population Health at the USC School of Pharmacy. She does everything, including runs a virtual care pharmacist program that offers MTM, everything from MTM to CMM online. We could not run anything without her. So she's going to give us an update on where the collaborative is today relative to our last learning session. Jessica.
All right. This one's easier for me to look at. Okay, so I get to talk about the good news because it's the progress update, and thankfully, thanks to LA Care, thanks to Inland Empire Health Plan and USC and really all our partners, things have progressed wonderfully since last summer. So last summer is when we gave the last learning session and kind of gave you some preliminary things, but now we'll tell you where we've been so far. It's not advancing. You said green button, right, Steve? There we go. Okay, so at the beginning, I'm just going to talk very briefly about team development. So when I say CRMC team, it's really everyone who makes this possible. So not just USC, but our health plans, our pharmacies, other stakeholders, really everyone that has been in this together and what we've done this last 10 months since last summer. And then I'll put a little focus on our two, really the stronger health plans who've been with us in this from the beginning and really where we've been since last summer with them and the CRMC pilots that they had been running, which are really no longer in the pilot phase. And then I'll end with just a quick introduction of what we've done with our data platform and documentation for CRMC. So over here, so when we talk about continuous team development, so one of the things just for our pharmacies, we've really progressed since last summer. So we started with two main meetings that we involve our pharmacy sites in, and one of those is the health plan, CRMC pharmacy and USC meetings. Those began as weekly meetings and have since then developed into becoming monthly because our teams have really moved from being novice pilot pharmacies to very advanced pharmacies that really have it down now. And that's why we've been meeting monthly. And in these meetings, there is one-on-one coaching, there are pharmacy check-ins, report cards like the sample that you see over here that are presented to the pharmacies for that continuous quality improvement. And really, it's just a nice monthly check-in to take care of with the health plan, its CRMC pharmacies and USC. Aside from that, we also have a pharmacy network forum meeting. And again, this used to be a more frequent meeting around bi-weekly, but since then has changed to monthly. And in this meeting, it's really a all teach, all learn perspective where we have all of our health plans, all of our pharmacies, covering different disease states. We have journal clubs, case conferences, for everyone to really learn from each other. So for example, for Inland Empire, they've had a focus on asthma versus LA Care, where the focus has been on diabetes, hypertension, and statins. And it's nice to kind of get people doing different things, learning from each other, giving feedback, going over difficult patients, etc. And besides the pharmacies, of course, the health plans. So we have monthly meetings, actually bi-weekly meetings that started as weekly. Since then, there's always this continuous conversation about how our CRMC pharmacies are doing, what payment models are we implementing, are they working, do they need to be adjusted, are we picking our highest risk patients, ensuring really that the health plan needs are met while providing the service and filling the gaps that are present, and then also discussing additional opportunities for improvement. So we're always not just doing QI for the pharmacies and the results of their patients, but even QI in the whole process. Are we documenting in the best platform? Are we getting the best reporting, research, analytics done on this program to show its value and to help it expand? We also have health plan meetings with prospective health plans. When we're very much growing with number of health plans joining CRMC, and then even other stakeholders that are very interested in this model of CRMC where it increases access to care. They might not be a health plan, they might be an initiative focusing on homeless people, or a medical group that has a high need for CMM, and the physicians are burnt out and are seeing 30, 40 patients a day and need this increased access and didn't know it existed. So CRMC is really opening up all these potential opportunities for various different stakeholders. So for LA Care alone, since last summer, before when we showed this, it was literally half, if not less, that you would see in terms of number of pharmacies. Now alone, we have 15 pharmacies, and you can see spread out on the map. So just in terms of pharmacy network, it's expanded greatly during this 2022 year. So we're very excited about this growth of pharmacies and consequently the increased access to care. And for clinic partnerships, over here you see about 8 clinic partnerships, which are also continuing to grow. And this is an additional thing that the health plan has been key and influential in doing with USC and the pharmacy network, is making those ties and connections and connecting them to federally qualified health centers and medical groups that have a great population in need of CMM services. So by doing this, we really help provide more connectivity between the pharmacists and the patients that they're taking care of, because they're more closely tied to their physicians and the physician groups taking care of those patients. So it really helps dissipate any fragmentation of care, any disconnect between the team, and really help connect the full team as an interdisciplinary team between the pharmacy, the physicians, the patients, the health plan, and really connect everyone. So results, initially the enrollment proxy was an A1C over 9, and that's really what LA Care started with as kind of a for the pilot phase. And since then, the progress update is really that LA Care has expanded this to include additional groups. So now there is a CBD cohort group, there's an adherence MTM cohort. They're also looking into a behavioral health cohort. So there are additional cohorts of patients in order to be able to improve and expand the expansion of services to a wider population. And they're actually finally have kind of confirmed these groups, and now starting to do enrollment in those various groups as well. And of course, the value-based payment model is tied to the metrics you see. So with diabetes getting to at least an A1C of under 8, blood pressure getting under 140/90, and then initiating a statin if it's as long as it's not contraindicated. The results you're about to see are only showing about 5 months of care, which is really, really impactful because usually for these very uncontrolled patients, it takes a good 8 to 9 months. But even just in 5 months of care, you'll see wonderful results. They enrolled about 354 Medi-Cal members with a focus on reducing health disparities. So you'll see 51% of those members were in Antelope Valley in South LA, while 29% self-identified as Black or African American. As you saw before, 15 community pharmacies and 7 clinic FQHC partners, and the average age was 53 years old with 45% male. Average A1C decreased by 2.4 points in this population, and the baseline A1C was 11.5. So you can see these were not, close to being at control. They were really from your hardest patients to take care of. And the average systolic blood pressure also decreased by 18 points with all the patients with patients above 140/90. Statin utilization more than doubled. So just in that alone, it was amazing. 90% of the patients with diabetes were pretty much on a statin unless they were otherwise contraindicated. And something that we're doing now that's, added and really a big progress update is we have physician leadership in data and analytics and research, both physician and pharmacists kind of leading the team and now taking all this data and doing a rigorous impact analysis to compare the intervention group with a control group. So soon we'll have that data to really show even more. Now it's not. Sorry, it's not. Okay, there we go. Oh. I'm trying to see if I can go back. I want to. Oh, there we go. Okay, so Inland Empire Health Plan has 8 participating pharmacies and is currently expanding into new pharmacies, some of which we see over here. So welcome to the California Right Meds Collaborative. And similar to LA Care, they've also shown great results. So you'll see over here. So like I said, their focus was asthma. So the program is a little bit different, but they're expanding to other disease focuses such as controlling blood pressure. And just preliminary results, they enrolled 156 Medi-Cal members targeting high and rising risk members based on the Johns Hopkins Adjusted Clinical Score System. And these were adult members located through the Riverside and San Bernardino County. And they identified members that lived close to the pharmacies providing care. So again, to increase access to care, to give them another area where they can easily go pick up meds, whether or not they're picking up meds, but receive additional services that they otherwise had barriers to accessing. And then their goals and value-based payment model is tied to improving the asthma medication ratio and reducing urgent care use and hospitalization. So if you look over here, just looking at the results, over 3 visits per member, you can see based on the asthma control test that is administered to patients during these CMM visits, between baseline and between the follow-up, you'll see that the green rises, so that those are your well-controlled patients. So you have higher numbers of well-controlled patients. And then you'll also see, if you even look at the red and yellow, that that's decreasing, of course, because you're not well-controlled and you're poorly controlled, we're also decreasing. There is planned expansion of disease states, like I said, into other areas of focus based on the health plan needs. And as well for them, we're also starting an ongoing rigorous impact analysis to compare the intervention group with a control group and really be able to use that robust data research to expand the program. So also an additional opportunity when I was talking about, connecting to different stakeholders that came out of California Right Meds Collaborative is a pilot study on CMM among hospital discharge stroke patients. So the California Department of Public Health Cardiovascular Disease and Prevention Program came together with Inland Empire, with Desert Regional Medical Center and USC to develop a unified stroke patient recovery pilot program to enhance the delivery and support of CMM to recovering stroke patients. patients. The aim is to evaluate the effectiveness of CMM services on clinical and behavioral outcomes in these patients who get discharged due to stroke, where they were admitted due to stroke, and see what can CMM do for these patients. The hope is that it'll improve their post-stroke high blood pressure control and prevent rehospitalization. So we're still in the early stages of this program, but we finally submitted all the processes, IRBs, et cetera. And the goal is to have this program run until June 2023. So it's an exciting new added opportunity that kind of came through CRMC. And then lastly, I'll end with the data platform. So in the spirit of continuous quality improvement, like I said, not just for our pharmacies, but for everything that we do, we've transitioned over to a new data platform called Arene, which is a healthcare data aggregation company that enables auto population of stakeholder information. So that could be information coming from health plans, FQHC pharmacies, the medical groups, and then the platform should provide robust clinical reporting, analytical tools to optimize the capabilities of our QI coordinator, real-time data and reporting and analytics to all the users, whether it's the health plan, the pharmacist, USC, really everyone in the care team, to just have a better and more effective way of documenting and reporting out. So that's kind of our last thing that we've done so far. It launched January 31st of this year. And we're just, hoping to continue, progressing and be able to give you an even better progress update next year. So with that, I'll turn it back to Steve and he will introduce our next speaker.
Thanks so much, Jessica. Like I said, Jessica is an awful lot for us, really grateful for all her hard work. Really now happy to introduce a couple of leaders that we've worked with for years now, working with two health plans. The first is Dr. Alex King from LA Care Health Plan. Yeah, Alex, I remember a long time ago, we sat in your office with Jana Paulson and talked about the concept. I took too long to get back to him and he got back to me and said, hey, what are we doing with this? So I really appreciate his interest and his enthusiasm moving forward. I'd like Alex to come up here and speak a little bit about his vision for where LA Care is headed with this program and others. Thanks for being with me, Alex.
All right, hi everyone. Okay, so there's two reasons why we're participating in CRMC. The first reason is because we want to help the pharmacy profession, right? Most of our colleagues and our pharmacists are community pharmacists. And what's the number one complaint that we hear right now, right? We hear about bad working conditions, about being overworked, and we're at the CPHA conference, but I'm gonna call CPH out and say those things like quotas don't work. You know what the number one problem is right now? It doesn't take, I got an MBA. It doesn't take an MBA to figure out what supply and demand is. We have too much pharmacists, right? And that's why they could treat you like crap when there's too much pharmacists. So that's another topic and I'll go along. I'll talk about that later, but maybe one day we'll discuss that one. So what can I do as a managed care pharmacist to help my profession? And as a managed care pharmacist, it is, hey, I could expand the role of the pharmacist. What can I do? I could the more expansion of the role we have, the more demand there is for pharmacists, right? And so if we have more pharmacists, there's more jobs there are, and the better treatment that pharmacists get, the higher pay we get, and it's just a better overall thing. So now, how does that help me as a managed care pharmacist, as a director of pharmacy? What can I do? I work for the largest public Medicaid plan, LA Care, in the United States, and we talked about CalAIM. We talked about, we were making a DSNP next year. We talked about all these things that my health plan is doing. So how can pharmacy get involved? We have other health plans in this line, and how can we get involved? Because we see the nurses getting involved, the doctors getting involved. Every department in LA Care is getting involved, but what can pharmacy do? And the great thing is there's a pharmacist literally on every block. Even with be an independent pharmacy, especially in LA County, we have 50% of pharmacies are independent owned. Either it be a chain pharmacy, either way, we have a lot of pharmacists that are in LA County. So what we decided to do is let's get our department involved. How can we get involved? Is to involve the community pharmacists. So we actually tried the pilot where we sent an AmCare pharmacist to the clinics. And guess what? That's trying to be Kaiser, right? And that's just tough. Unless I'm going to hire 100 AmCare pharmacists that are going to go out and do this, it's not going to work, right? It's not going to work, right? But there's a pharmacist, there's a community pharmacist that's been going to school for I graduated school over a decade ago, and I know they were teaching this 10 years ago. So how about the new pharmacists now, right? There's like, there's 50 pharmacy schools in California, is it, right, by now? And they've all been teached all this clinical knowledge. And what happens when they get to the community setting, right? 90% think they're gonna be clinical pharmacists, but 90% end up being retail pharmacists, right? And all this knowledge goes to waste. So we need to figure out how to get this knowledge that they've been learning for 4 years, 3 to 4 years, and being used to help their patients, to help everyone, right? Society. So what CRMC does, this is what we've decided to do. When you see the impact that CRMC has, I kind of have the same slides as what Jessica has, all of our results. So, at the end of the day, the only slide that really matters, I'm going to tell you right now that I did not make these slides. Someone that reports to me made it. And the only slide that I like that they made is this slide, which I'm going to show you right now, right? Keep going. Is this slide, there's one more slide, right? So what can we do as a health plan? Why is it so important for us, right? It's because when we get involved in the pharmacy department of a health plan, right, we could show good results. Like, I don't know how other health plans work. The good thing about, I like working in the pharmacy department in a health plan, and then I've worked in a couple of health plans before, is because, pharmacists have a chip on their shoulders, right? We try a little bit harder to help our patients. And I see that in my colleagues, right? And I see that in the community. So what can we do? So we have all these pharmacies that are overtrained, right? And they're ready to go. So we as a health plan have to pay money, right? Because the number one thing that we don't like as a profession is pharmacists doing services that aren't being paid for, right? And that's the number one thing that we as a plan could change, because we're the payer, right? And as a fellow pharmacist, how can we get more services paid for by our plans so that our fellow pharmacists increase the supply, demand for pharmacists? And one of the ways we can do it is by paying for the services. We've always talked about, I think I've talked to some old timers in pharmacy, and they talk about like how Amcare was going to revolutionize pharmacy, and it hasn't. And they talk about all these other that one day pharmacy will change. Well, this is the start of it. And how does it start? It starts with the payers, right? Because we have to go where the money is available. And so what we're doing in LA Care Health Plan is by paying for services where it's, the basics of CRMC is basically Amcare at the community pharmacy level, right? That's the base bottom line of it. And does it work? And it does work, because we see from this little trend right here, this little graph that someone from my staff who's really probably decent at charts made. The more visits that a CRMC pharmacist has, the greater the A1C reduction. And that helps with our HEDA score, our 5-star score. And that's the reason why you as a health plan should be pushing this, because we're actually seeing results, right? That's the bottom line. Because at the end of the day, like, let's face it, if we spend all this money as a plan and then we get no results, right, we're gonna get blamed, right? And then I'll probably blame it on someone who's lower level than me, and then we'll get rid of them, but you'll be safe. So it's okay. So give it a try, and then blame someone underneath you if it doesn't work, right? So, but at the same time, this will actually help our profession, right? Better results for our number one, better results for our patients. But number two, it's gonna also help our profession. So it's a dual-edged sword that's really gonna just be able to expand our what we're trying to do. So if you can see that this is happening right now, right? This is going so well for us, right? That we're actually expanding, Jessica talked about, so we're actually expanding to like behavioral health. That's another CalAIM, we have a lot of issues with behavioral health, and we showed our results to our behavioral health department, and we've shown them the results, and we're actually gonna expand this to include behavioral health medications and counseling by the CRMC pharmacists. Why? Because they're at every pharmacy. They go pick up their meds. Let's talk about behavioral health. So how can I convince you to do this? There's only 2 reasons why you should do this, right? Like I said, we're gonna come back to it. I like to sum things up. First reason, it's gonna help your it's gonna help your profession, right? You're a pharmacist too. Sometimes you take away, like I think the biggest challenges I have, right? Like my biggest frustration as a managed care pharmacist is that some people, you forget the struggle, right? Like I'll be honest, I've never worked community before, except for when I was a student. And I talk to my community pharmacists and they talk about how hard they are, how hard the profession is, right? They get the burnout. You hear all that. And sometimes you might forget how hard it is. So I can't relate, but I could empathize, right? I could see what's happening. So what can I do, right? I'm on a big, well, I haven't gone into the office in 2 years, but I used to be in downtown LA on a big high-rise building, looking down at the people going, oh, I'm so good, making the big bucks, going like, and what can I do? But that's not what, what's good for profession, right? What's good is that we expand the pharmacist role. So that's number one thing. I want to expand pharmacist role. And I think that will really improve the situation that we're all in. And number two is I got to do something for myself. Let me be a little selfish, right? I want my department, especially my health plan, for us to look good by showing a lot of good results, right? We, especially like, the main things for my Medicare line that I'm responsible for the adherence metrics. We've shown that every CRMC pharmacy has better adherence metrics because they're more aware that we're looking at, they're looking at the CRMC patients, but also the other patients that are LA Care. They are fully aware that we're looking at everything. So it increases adherence, 5-star for that metric. Our HEDIS metrics for Medi-Cal, we're still responsible for all the clinical outcomes. So we're seeing increased like metrics for pharmacy in general. So it makes my department look better. So it's a win-win for everyone. Win-win for the profession, win-win for my department. And the cost involved, there is cost, but when you look at the cost that we're spending and then the reduction in A1C, it's easily provable that we are actually saving a lot of money, right? When we don't get the, someone going to ER for hypoglycemia, when we don't get other like side risk factors, we're seeing that it's so much better and it's going to save us money. So number one, help profession, save your department money, and help your patients. Those are the three things that you should take away. And that's the reason why we're doing it. And you could probably see my slides later because I don't even know what they said, right? But I'm sure they're nice slides and you could see them. But I hope you remember my 3 takeaways, and we do this for our patients and ourselves.
Always look forward to hearing Dr. Kang's update. I don't think anyone is quite as transparent, which I greatly appreciate. But I want you to think about something that he said. I rarely hear a health plan say that we're here to help pharmacists thrive. That's just so uncommon. So again, greatly appreciate your leadership and vision. Thanks, Alex, for sharing that with us. Next we have, I'm going to move these forward. We have 2 guests from Inland Empire Health Plan, folks that we've been working with for quite some time now, Dr. Michael Blatt and Dr. Tim Liu. I don't want to read all the bios because there's just so much info in here, but really quickly, Dr. Blatt is Director of Clinical Pharmacy and Product Strategy at IEHP. He's had a lot of experience in managed care, worked in the Central Valley area as well, and I keep telling him, joking about this, for a guy that probably has not had a lot of clinical experience, he has a lot of clinical knowledge. I was really impressed with the way he approaches problems and comes up with great solutions. So great to partner with him. He is a UCSF grad. We love UCSF. It's no biasing. On the other hand, Dr. Tim Liu is a graduate from USC School of Pharmacy, currently a senior informatics pharmacist at IEHP. Really a pleasure to work with him. Always on the ball in terms of finding solutions that work for our network partners and for IEHP. They're together going to give an update on what's going on with IEHP, where they're at, and what their vision is for the future with CMM. Come on up, guys.
Okay. Hello, everyone. Thank you, Steve, for the kind introduction, and thank you, Alex, for giving me a hard act to follow up. So Steve introduced us. We've really developed this CRMC because really it's a critical need for the Inland Empire. Inland Empire is composed of 2 huge counties, San Bernardino and Riverside County, and covers like a huge amount of area. It's a kind of two counties that, a lot of people kind of forget about, but there's been quite significant growth. A lot of the people that cannot afford LA, they move into those areas, and significant population growth. And when I started at IHP 3 years ago, we were at 1.25 million members. Now we're at 1.6 million members. And so one of the key things is, how do we deliver care for this growing membership? There's not enough PCPs in our rural health plan. It's a very rural area, and a lot of physicians, they'll come into the area, practice a couple years, come out. Even when they come, there's not enough. I think I've read a statistic that we have it's tied with the Central Valley. Again, I served with a plan that covered the Central Valley. Another plan two areas that have the biggest shortage of PCPs in the whole country, not just, in California, but the whole country. So kind of like what Alex said, in the pharmacy school, we learn all this clinical stuff. And yet when I used to practice at Target, I graduated in 2014 and had a robust 3-month retail pharmacist career, and learned that I wasn't very good pushing those 5% discount cards. Every 5 prescriptions, you get 5% off for my Target alumni, right? I learned, wow, I'm not really kind of using my license to the top. So then I went to this managed care field. I was like, cool, I'm doing prior authorizations, managing the formulary. But then I started talking to pharmacists and thinking back, and I'm like, wait, am I really adding value to the pharmacy profession by, taking metoprolol ER off formulary because it's $5 cheaper than metoprolol IR? Those savings are marginal. And so when we met with Steve and Alex and the USC and LA Care Group, we started learning about alternative models on how we can really push the pharmacy profession. I have a great mentor, Dr. Ed Jai. He did stuff like bringing a lot of ambulatory care services in LA County and stuff, and all the different places. And we're like, how do we bring this not just to health systems, but to, the community pharmacy? Because as was just said before, like 9 out of 10 pharmacists are in the community setting. At the same time, we have major disruption in this area, right? With the Amazon, all the mail order mandates, et cetera. I think, people are getting used to getting stuff in the mail now, right? Before it's like, hey, how can I get my meds in the mail? Now it's become an expectation. So what value are we bringing as community pharmacy? Through developing services such as this, where, hey, the patient may not be able to see their doctor, but now they have this clinician that's able to provide clinical services right at their doorsteps. So this slide is just kind of talking about the collaborative. I don't have any financial relationships, and Tim has no financial relationships. And again, this is like the IHP membership, and this is out of date already. I think you made it a month ago, Tim?
Yeah.
1 month, it's out of date. We keep growing. With CalAIM, we added tens of thousands new patients in Blythe and Needles. And for those home, you guys probably didn't want to drive here because you'd have to drive through those areas, right? Very rural areas, long drive stuff. So again, not enough clinicians. So how do we really develop our network? And so this is, again, our reason for action. I kind of said, this is the state recommended primary care doctors per 100,000, and this is what we have in Inland Empire Health Plan. And I'm pretty sure we're not going to graduate enough physicians to cover that gap. We have to figure out how to utilize other clinicians, and the community pharmacist is one of those. And so here's some of the key challenges, right? One is, a lot of these community pharmacists, they have provider connections, but how do we strengthen them and get the providers to trust? How do we get patients engaged, educating the patient that, hey, you can have your pharmacist adjusting doses, et cetera. And then finally, the health information communication. There's a lot of data that goes into it. Those already participating kind of see some of the challenges of us sending info, whether we send info in an Excel sheet, CSV, this, that, all this computer stuff, right? And so I'm gonna let Tim, who's our senior informatics pharmacist, finish up the rest of the presentation because he's been a vital driver for this program. Tim, take it away.
Thank you, Dr. Blatt. We're really proud to be participating with CRMC and working with our pharmacy partners to really create this program. We work really hard communicating with each other in order to create a really streamlined process. We've ultimately tried to overcome all of these challenges that Dr. Blatt had mentioned, and we created a framework that helps align all of the goals that our health plan, our providers, our pharmacy, and our patients. So ultimately, we've created this process in collaboration with CRMC and our pharmacy partners through our rapid improvement event. We went through back in August, a 5-day event where we worked with our CRMC members as well as our pharmacy partners to create a streamlined process that helps close all the different gaps in care. The communication between our providers, the communication between our pharmacies, as well as our patients as well. We created this product so that any areas that we need improvement on, we're here for continuous improvement. We're always looking about making ways to make a positive impact on others. And so we've created ways so that we can involve our key players and ultimately create a product where we have collaborative practice agreements and EHR access so that we can communicate information in a timely manner so that we can make the most impact with the most recent data that's possible. And lastly, like Dr. Blatt mentioned, access of care is a really big concern for us here in the Inland Empire. And so we've really improved our access of care with the major improvement with telehealth. We made a lot of strides in our program so far, but like I said, there's a lot of opportunities for improvement. So right now, our opportunities are addressing social determinants of health, collaboration and coordination of programs. There are a lot of different programs within the Inland Empire that are a little siloed at this point in time, but these are good opportunities so that we avoid double work and create a lot of these programs such as transportation, behavioral health, and health education so that we can meet all the needs of our patient. And so this is one of those opportunities that we'll be working with our Riverside organizations, our Inland Empire organizations, as well as internal department programs as well. We're going to be continuing to improve our efforts for reaching those harder to reach patients and also closing those gaps in care, like I mentioned, and also improving those quality measures. And so for our future program, what we're looking for is to continue to expand our chronic disease states. Right now, we're currently at asthma, but we're looking to improve and expand those so it's a very holistic approach, including hypertension, diabetes, and many more. And so we're going to be developing our value-based payment models so that they compensate for the time and the effort, so it makes it that there's value for everyone. And so at the end of the day, our program is to expand our program. We're really looking forward to continuing to work with CRMC, as well as our pharmacy partners in the future. Thank you.
All right, thank you both. I think you understand now why we ask our health plans to speak first. These guys have vision and they want to push the profession forward, do the right thing for patients. Mike, you said something very important. You had that epiphany moment at Target when you asked yourself, how do I add value to these patients I serve? And I think that's that mindset you have, Mike, that makes you so good at what you do. So thanks for that very much. And Tim, he's so meticulous. I think we drove him crazy with all our questions, and he never fails to leave a positive note in an email of some sort. So I also appreciate your attitude. All right, so moving on from, and I can't advance, but that's okay, because we're going to have a couple of our teams now share some of the work they've done. Now, the teams that have been in the collaborative have matured over a good amount of time, and they have really impressive programs now at this point. And so we're really excited to have one team from LA Care and one team from IHP share their story. And something Tim had also mentioned, this emphasis on social determinants. We can't underemphasize how critical that is. And I think the health plans have just been so instrumental in empowering our pharmacies to just not be places where they get med management, but they also get management of these critical social determinants that can make all the difference in their outcomes. So really great work from both the health plans. Dr. Janice Cooper Knight is owner and clinical pharmacist at Manchester Professional Pharmacy. She graduated from Xavier in Louisiana, completed a great residency program over at the VA Long Beach, worked in Kaiser as a AmCare pharmacist. So she really is a clinician in training. And as I like to say, she's a gem in her community in terms of the impact she has on the patients she serves. She's CDE, she's a certified diabetes educator, has just done tremendous work in diabetes. And she's going to share with us some of her secrets to driving maximum impact from comprehensive medication management. So Janice, I hope you can share slides. I hope are you able to do it? Yes, great.
Okay.
Please take.
Hi, everyone. I had asked for someone to advance my slides for me. Is that possible? Okay, thank you. I have no disclosures at this that I would like to say. Okay, so I'd like to start though with just a little background. I started in pharmacy as working in, actually, I don't know if anyone remembers Thrifties for a while. Then I wanted to use my clinical background a little more. So I moved over to Kaiser. After Kaiser, for a little while, then I decided I really liked the community setting. So I went back and opened a pharmacy, and I had the notion that I was going to be able to use my clinical services in that capacity. Coming through the years, it has been very, very difficult to actually work in that capacity, utilizing the clinical background that we have. I talk to the patients, and we talk about as much time as we can give patients these days. We talk about the medications they're receiving. We're doing the MTM. I actually add on what is if they've received blood pressure medicines, what's your blood pressure? What was your blood pressure the last time? The first question is, I don't know. Doctor says it was okay. Okay. Diabetes, what was your A1C? What is that? Are you testing? Yes. For what your numbers? What are the numbers that you obtaining? I don't know. So that's when I realized that there was we have a disconnect someplace. At that time, I started trying to approach physicians or medical groups, and that was not a very good experience. And so coming through the years, we've been doing a lot of clinical trials, a lot of grants that I worked through trying to show the benefits of actually having a pharmacist on the care team, working with patients. But once the grant stopped or the clinical trial stopped, everything stopped. So moving forward, a couple of years ago, probably now about 5 years ago, I met Dr. King at a one of the meetings for CPHA. And I went to one of the programs, and he spoke, and afterwards I asked him about it, and he says, no, we're working on this program where community pharmacists will be able to provide more clinical services for patients because we see patients the most. And I kind of chuckled and laughed, and I said, okay, we'll see. But here it is. So I was very excited about this program. And so why is CRMC important to me? Because I see patients on a daily basis, and to see the benefits that they are obtaining from this program. Number one, diabetes. The patients identified, we reach out to them, we talk to them, we get background information. Now, everybody's not on board, so we are still trying to get through that process. But the patients that are on board actually appreciate the program. They actually call me to tell me what their goals are, what they their lab work, they'll bring it in, we discuss it. And even if I'm not able to reach out to the pharmacist, to the physician, because I know a lot of them, as was mentioned, they have 30 to 40 patients a day. It's no way they're going to be able to talk to the patients. And then I can actually we talk about the medications they're on, why a lot of times we have been able to understand why they are not taking their medications. I have a couple of patients that do not take the GLP-1s for diabetes because it makes them lose weight too fast. And so they stop taking the medication because they say, people start asking them, are they sick? So that's something that we have to understand, that as far as what people's perception is of medications, how it's working for them, and how we can make changes, how we can actually speak to them about the benefits of the medications. But if they're not going to take the medication, bottom line is it's not going to help. So our first thing is, what I'd like to do is actually we develop a relationship with the patients to help them understand what we're trying to do. I tell each patient, your health matters. Now, it depends on how much your health matters to you, to me, to the physician, but bottom line is it has to matter to the patients, and that's what we work with. Improving health equity. What I have learned from the program is that a lot of the clinical groups, medical groups, as they were mentioning, the physician is there for maybe 3 to 6 months. Then they switch doctors, or a whole new team comes in. Well, at that point, the new doctor changes all the medications. So we have to start all back over again as far as what medications are working for them, their health goals. So at that point, if the medication is working for the health goals, that's what we work with. What are your health goals? A lot of patients get upset when their medications are changed. They get upset when the physician is changed. They stop taking everything. So having the patient understand what their goals are and what we're all trying to work to reach these goals really helps them. Also, once the physician leaves, they can call the pharmacist, and then we can help them understand what's going on. The next thing is that the CRMC program helps us with all of the new guidelines, and that's the most, challenging or part that has been actually the best for me, is that all of the programs that we have, as I think Jessica mentioned earlier about, we have the monthly clinical meetings, we have the team meetings, we go over guidelines, best practices. Not everything works for each patient, and that collaborative process really works. You have someone else you can call and learn new things. And then being a part of the patient care team. It's great for a physician to reach out to you, okay? It's great for the patient to reach out to you, but it's excellent when it all works together. And the process is basically the patient reaches their goals. Next slide, please. I had just talked about that. Next slide, please. Okay, overcoming challenges. Well, when the CRMC program started, COVID hit. So that was a major challenge to overcome. However, as a community pharmacy and pharmacists, we were still engaged with the patients. A lot of patients could not get their medications. A lot of the patients could not have their blood pressure checked. They didn't know what to do with their diabetes. Stress made their diabetes go up. What do they do? So at that time, it became very important for the clinical pharmacists for this program, because we were able to fill in that gap between the patient, the physician, medications, all of that. Physician engagement was great because a lot of the physicians were not at the clinical site. So actually, we were able to send them information, let them know the patients needed refills, let them know the patients, their blood pressure, their diabetes levels, and all of that. And so the next one was actually I felt we became an important member of the patient care team at that point. Actions to improve. We have to make changes to existing workflow. There's no other way around it. Just to set up the talking to the patient, you have to carve out time. And understanding all of their information they're giving you. We have to call pharmacies, we have to call the physician's office. So the existing workflow does have to change. Establishing collaborative practice agreements, that's something new for myself. And having the physician groups and the medical groups understand what a collaborative practice agreement is, how the program works, and how this program will help for us to become a member of the patient care team, which is very important. Also, it improved clinical skills. As I said, the programs that we have where we have the journal clubs, we go over new guidelines, new medications that are coming out, how they work, the medications that are out, and how they can work better for the patients. So that was excellent. Next slide, please. Oh, okay, so that's it. Alrighty, so I would like to add though, the most rewarding for me from the program has been the able to help the patients that really want to or searching for help. Some of them don't realize they need the help, but to be able to provide that assistance and the understanding of how their health matters and how they can really understand their health and be able to make differences for themselves. They are just excited. And when they come in and they told me their numbers and how they're doing, and then they'll ask me, okay, so what else can we do next? I know I need to get down to a 7, so, for diabetes. How can I do that? What else can you help me with? Medication-wise, or we talk about foods, we talk about exercise. So it's just so exciting. And that's it.
Annis, thanks so much. I always love hearing you speak because it brings me back to my practice days. You're so good at engaging patients and working with them. We're gonna have to drag you out here again to speak specific on that on a future date. Thanks again. Next, we have Dr. Keith Fujinaga, Director of Pharmacy at Inland Behavioral and Health Services. I've known him actually longer than CRMC. I'm sure he remembers this. He was working on developing CMM programming with another organization when we had met, was really impressed with what he was doing back then. And so when this opportunity came up to include him in Cal Right Meds. We jumped all over it, and we're so thrilled that he's part of this. In my opinion, Keith is one of the best clinicians I've seen in any setting. He brings lots of great insights. He has, in a sense, somewhat of a more integrated practice than most places because his pharmacy is within Inland Behavioral Health, the clinic itself. He's very committed to CMM, but also very committed to bettering care for the underserved, both physical and mental health. So he will also be sharing some of his pearls on driving maximum impact on CMM. So thanks, Keith, for joining us.
Yeah, thanks, Steve, for that generous introduction. So hello, everybody. My name's Keith. Work for Director of Pharmacy for Inland Behavioral. I'm kind of jealous of you all in Vegas. I lived there for 11 years. But I want to make sure you guys all know that the locals there do call it lost wages for a reason. So just be aware of that in your finances. Okay, so let's move on to basically talking a little bit about my facility. We are FQHC, and we're going to be talking about advancing comprehensive medication management for maximum impact and efficiency. So of course, we partnered up with IHP. Thank you very much for providing us this opportunity. So if you want to advance the next slide, please. So I have no actual potential conflict of interest in relation to this presentation, and no relevant financial or non-financial relationship with the products or services described and reviewed, evaluated, or compared in this presentation. Next slide, please. So a little bit about us. Like I said, we are a community-based, nonprofit, federally qualified health center. We have 3 main medical facilities in San Bernardino and 1 in Banning. San Bernardino, just to give you a background information about the population here, it's very filled with a lot of people who are transient, homeless. A lot of them are underserved, unserved, and a lot of them have very complex and high risk chronic disease states for them not receiving access to services. Many of them utilize ERs and hospitals as their main form of care. Next slide, please. So we're going to talk a little bit about our experiences with CMM, how to maximize it. So the first thing we kind of did, like Steve said, when we first started, was we wanted to kind of create a workflow. And I think this is different for each pharmacy and entity. So here at our facility, like Steve said, we are a pharmacy that is incorporated with our health center. So we do have access in building within our 4 walls to doctors, to nurses. And prior to this project being started, we were specifically just community pharmacy. We're known as a 340B pharmacy, so we were just dispensing. So we started to look into the angle of clinical care and pharmaceutical care, try to see if we could work our way into the medical department, because there was a lot of pushback initially. So this is kind of just a high level workflow. If any of these documents you see anyone's interested, I'd be happy to share. So just let me know. So next slide, please. One of the important things that we noticed was the checklist is pretty helpful. So a lot of times when you're doing CMM with a patient, because they have so many complex disease states, so many things that may bother them at that certain day, you tend to go tangent on your session. So a lot of times when you could get through the specific disease states that you want to concentrate on that are highest risk, it may transition to something like, I kept having to use the bathroom last night and then I had pain. And so it kind of gets off tangent. So we noticed that a checklist kind of brought the pharmacist back in to make sure they didn't miss anything. And that was very helpful. After the visit, we made sure that we assessed our goals. We identified some problems, any gaps in care, and anything that we had to communicate to the provider or referrals that the patient needed, such as labs, specialists, certain diagnostic tests. And then we provided our recommendations to the provider. Next slide, please. This is just another high-level tool for the pharmacists. We kind of make sure that we look at the medication portion, if it's appropriate for the patient, why are you taking it? A lot, like I said, a lot of the patients here utilize the ER or hospital. So they're on hospital discharge medicines that they may not need, such as H2 blockers, long-term PPIs, those kind of things. We even have people that are on antibiotics for no reason that keep getting refilled, or corticosteroids for no reason. So we utilize this to make sure that we have our base of medication review and reconciliation, and that each of these things get touched, so that we are pretty comprehensive on our medication management. Next slide, please. The biggest tool that has helped us here at IBHS is our collaborative practice agreement. So it's pretty robust. When we first started this, it was proposed to just do it for our pilot disease state, which was asthma. But I kind of thought I'd have only one chance of doing this for the medical director. So I kind of incorporated all the disease states that I thought would be comprehensive and included, as you see there. So it goes from anticoagulation down to immunization. So most of our biggest disease states here at the health center, I tried to include it. The thing that provided buy-in was we have a P&T committee, and we present clinical guidelines. And so CRMC is very helpful for us because they have journal clubs, they have tools that we utilize for evidence-based medicine. And a lot of the providers here, they're not really versed with the current treatment protocols and guidelines. So when we present those things, they kind of open their eyes and understand the value for pharmacists. So in the CPA, we make it pretty comprehensive. We allow ourselves to do labs, to make therapeutic interchanges, those type of things. And so it really helps us to make sure that our treatment plan is followed. Next slide, please. Early on when we were planning this, we were trying to think of how do we show value to, number one, our stakeholders, our C-suite, the providers, and patients. So this is one of the most important things I think you can do in CMM is do a survey. So the first survey we did was actually for providers at our P&T committee. And so we kind of just asked them like 3 or 4 questions about what do you think the value of pharmacists and medication management would be within your practice and with your patients. And to be honest, the first time we gave the survey, most of the doctors says there's no value for pharmacists to be part of our visit. So we were kind of shocked by that. They pretty much said, I send a prescription, I want you to fill it. And we're going to utilize glyburide for this patient. We don't need metformin because they have diarrhea, those kind of things. And our A1Cs here were, when I first got here, were 9 and above. We have people that are 11, 12, 13. So it was pretty bad. So we kind of introduced and did before asthma with IHP, we actually did diabetes. So we kind of just introduced a huddle with the doctor. We did find a medical provider champion that was willing to listen, and the evidence-based clinical guidelines that we offered really opened her eyes in regards to the SGLT inhibitors, the GLP-1s, and its role within the cardiovascular type risk. So she kind of bought into that and saw value with it. And as soon as you find a champion, the other doctors start to notice how are your patients starting to drop from 12 to 7. So she says, hey, I include the pharmacist. It's really good because I take care of the diagnosis, the assessment, and I send a referral to the pharmacist for the complex patients, and they work with the meds, communicate with me, and they make sure that I don't have any gaps in care. I forgot statins or aspirin for a patient, and they remind me to provide this care, and the patient has overall better health, better quality of life, better measures. So the value was pretty important. The survey did show at the next P&T that all the providers said we are valuable. And currently, every single provider here relies on pharmacy. They want us to be involved in every grant and disease state, and we get referrals constantly. Dr. Bao is my clinical pharmacist, and so he's pretty busy getting referrals for all disease states. He's currently involved in several clinical projects. The latest one being what's called SMBP, or self-monitoring blood pressure grant, where he's providing a device that connects to our electronic health record, so the provider can see the patient's numbers and he recommends treatments based on those things. So patient survey is pretty important too. We kind of ask the patient how you feel, and a lot of them at first say, I don't see value with this because my doctor knows what I'm on and what I need. But soon, like I said, when we change glyburide, the patient comes back and they stop by the office and just say, hey, my A1C went to 7 just by the one medicine. So they start to see value, and we start to notice the value of pharmacy, and it changes kind of the culture. So a lot of times when I don't know if anyone else has experience, but when you have someone just come up to you and go, what do you do? I'm a pharmacist. Which retail pharmacy do you work for? They don't really see us. They just see us as the lick, stick, pour. They don't see us as a provider or having the knowledge to provide clinical expertise on medications and how that affects disease states. So this survey kind of helps us to do that and allows us to show our C-suite and stakeholders the value. Next slide, please. So this is just some of the measures that we take, clinical measures, of course. For asthma, we took the peak flow, we track blood pressure for hypertension, and we look at adherence. Patient impact, like I said, we do a survey for satisfaction. We get testimonials and stories from patients who love it. And we start to see people start to get interest in their own disease state. And they come by and they say, I just took my blood pressure by myself several times, and I notice when I'm sick, my blood pressure goes up, or if I'm stressed, it goes up. And so we kind of empower them to care for themselves. Provider impact, like I said, the survey and having a champion really helped. We work with an interdisciplinary team with the providers all the time now. They always want to include us in their meetings. And they notice that their time with the patient is significantly cut down, so they can concentrate on diagnosis and those type of things, knowing that the pharmacist is there to help with medicine. Utilization, we track our ER visits, discharge patients we try to get in here in the clinic and provide CMM to make sure there's no excessive or missing discharge medications. We track the hospital readmissions, and we just emphasize the adherence to medications. That's one of the big things right now. We're starting to see a pretty uptick with COVID happening, of people coming in with hypertensive crisis because they're not taking their blood pressure medicine. So we're having to adjust a lot of people, and that's kind of why we went with the SMBP project, because we're using a lot of clonidine in clinic to get this hypertension crisis controlled. It's pretty crazy as of late. And then finally, operations, therapy encounters. We make sure that we have follow-up appointments and we verify that referrals are met. Next slide, please. So barriers, like I said, key thing is to find a champion medical provider. When you have a high turnover rate in your staff, re-education is pretty important so everyone understands what the process is and that the service is available. We make sure that we're in constant communication with the providers, because that's what kind of gives them the confidence to give you a sense of trust to utilize your CPA to the fullest. One of the hardest things for us initially was using motivational interviewing, and it was CRMC and Dr. Dree that actually showed us this technique, which was really, really beneficial, especially for our population here, who tend to not want to change a certain disease state, because I'm trying to see what my next meal is If it's McDonald's, it's McDonald's. That's the cheapest 99-cent meal I can get. So motivational interviewing kind of is a really important technique, but it's really a high learning curve. As stated earlier, the CPA, make sure it's encompassing as much disease states as the providers trust you with. Will provide you more access to linkage of care, and reimbursement is important too because it provides sustainability. So, of course, everyone loves to do the work, but without the compensation for our valuable work, the program cannot be sustained. So one of the things I said in the chat was a huge opportunity for us would be for federal CMS to view pharmacists as a provider. They do not view us as a provider, so we are not billable. But yet the federal government has been using pharmacies to administer vaccines for testing. So they definitely see our value, but we just need to utilize the consortia to try to make sure that we get reimbursed for that and can sustain our services. Next slide, please. Accomplishments that I want to share is, next slide, please. I'm sorry. Accomplishments I want to share is that we did have the opportunity to join CRMC and IHP. CRMC is pretty important to us as a consortium. Like I said, pharmacists are, for the general public, are looked at retail pharmacy only and just filling whatever the doctor says, doctor having majority of the knowledge. So CRMC kind of advocates and communicates to medical professionals, health plans, the value of pharmacy clinical services and the value to save money, decreasing hospital admissions, ER visits, and improving the quality of care of the patients. They help us to overcome some of the challenges with patient outcomes. They utilize a great database for us to document and have reporting. And they provide a lot of evidence-based clinical guidelines for us, updates, new journals, and those are type of things that provide trust with the providers. And they also provide a lot of trainings and certifications, which is very valuable. So that's pretty much our experience here to maximize our CMM. So thank you.
Thanks so much. A lot of sage advice there. I think for teams that have not done this before, Keith talked about a lot of the keys to relationship building, developing processes, CPAs, et cetera. So lots of great wisdom between Keith and Janice. Thanks so much, both of you, for sharing best practices. I know we're at the break, so I'm going to take just 1 minute to just give you a little bit of information on what I was going to cover and then let you guys go. We're not going to have a discussion. Just going to have you drop something in the chat. If I can give the next slide, please. Okay, next slide. Oh, am I doing that? I'm doing that. Never mind. Okay. All right. So I was just going to, just for a minute, talk about Covered California. Just so you all know, the CalRightMeds Collaborative is officially listed as a vendor under Covered California. What does that mean? That means that it's recognized as a tool to achieve the goals and strategies that Covered California has set forth for 2023. Really exciting. And this is thanks to CPHA, as well as the California Chronic Care Coalition and other partners that helped arrange an opportunity for us to talk to leadership at Covered California about this work that we're doing. Their conclusion was, when they saw this presentation on CalRightMeds, that this is exactly the translation of what we have in terms of goals and vision and what we want to see in practice. Value-based, health disparities, chronic disease control, culturally competent care. These are all things that are important to Covered California, and they very much recognize that we were doing this. Again, I won't cover all this, but the bottom line is health plans are struggling in Covered California. You can see there's not much green in terms of scoring for these health plans. And many of the metrics are the very metrics that we are tackling in CalRightMeds. So looking forward to further expanding that partnership. We are meeting with Covered California shortly to talk about how to incentivize health plans to join our collaborative. And that incentive is going to be facilitated through Covered California. So again, no time for these. I will close with this. We are partnering with Healthcare in Action, which is a subsidiary of Scan Group Health Plan. Basically, it's a street medicine program that's payer agnostic. So they will send, as you can see, a team of a nurse practitioner, social worker, and 3 peer navigators, basically people that were formerly homeless, out into different homeless areas 1 day a week, but a half day a week, and deliver street medicine care. And we bring this up because the person in charge of this, the CEO, Dr. Michael Hochman, is very familiar with the work that we're doing, being that he was our partner when we had our CMMI grant with Ultimate Health Services. And so this is the ask. He's looking for pharmacies that will help with medication dispensing, basically pre-packing medications and limited supplies that the teams would pick up from the pharmacies and bring over to the homeless areas. Comprehensive medication management, they will have they'll pay the pharmacist for that half day a week, about 4 hours to spend time with their team, caring for the homeless patients. And then on the flip side, those other 6.5 days a week, the homeless patients can presumably get some CMM follow-up from the pharmacy. So the pharmacy becomes sort of a medical home for those homeless patients. And then administration of long-acting injectable antipsychotics. Now, what's in it for the pharmacies? There's the Medi-Cal business, dispensing fees associated with the medications, of course. They did propose trying to tap into the Medi-Cal MTM payments for CMM. They haven't really figured that out fully, what that means, because anybody can do that. This is more a directed program, so we're still working on that. And as I said before, there'll be a stipend for joining the teams on site, as well as the increased revenue from the long-acting injectable antipsychotics. So if you're a pharmacy in any of these areas, Alvarado Street in Los Angeles, West Hollywood, Cedars-Sinai, College Medical Center in Long Beach, or the LA River encampments near Long Beach, contact us if you're interested. We're gonna have an info session in May for any pharmacies that would like to participate and learn more about this. And with that, if you wouldn't mind, as you take this break, which you now have, I think, we'll give you about 5 minutes, right? Maybe 5-6 minutes. Type this into the chat at some point. Answer these 2 questions. What can you offer that aligns with the needs of the opportunity shared, sorry? And what can you adapt to improve the quality of medication therapy for the patients that you work with? With that, we'll see you in about 6 minutes. Thank you. I don't know what happened. Like just now, it just killed. Let's see. Yeah, see,